Okay, so we're going to review testicular and scrotal ultrasound, or scrotal disease. There'll be a little bit of ultrasound too. Hopefully everyone took the quiz, pre-quiz. We're going to review the anatomy, talk about neoplastic processes, and then do some diseases that can present with acute scrotum. Let me make sure I have your chat box up, so I don't see it. Chat. Okay, so as usual, feel free to drop your questions in the chat box if you have any. The stroma of the testes contains which of the following cells? Sertoli cells, Leydig cells. Maybe I need to open this up. Okay, Sertoli cells, Leydig cells, or spermatogonia. So the stroma of the testes contain which of the following cells? Okay. You know, I want to see the chat box, but when I have it on Zoom, okay, everyone says Leydig. All right. Sorry. When I have it on full screen so that you can see EndNote or pull everywhere, I lose the chat box. Seminiferous tubules contain which cells? Spermatogenic cells and Sertoli cells, spermatogenic cells and Leydig, or Sertoli and Leydig? Seminiferous tubules. And everyone responded as A. Good. Sorry, once we finish these, we can go back to the normal orientation of the slides. Sertoli cells have which receptors? LH, which is important for testosterone production, or FSH, important for androgen-binding protein production, and estradiol. Sertoli cells have which receptors? Okay, and the answer is, most people thought B, FSH. Good. Okay, what is the most common testicular cancer? Non-germ cell, germ cell, or Leydig cells? Non-germ cell, or Leydig cell? And everyone said B, germ cell. Okay. Okay, perfect, good. So we're going to proceed. The embryology. So the testicles start in the abdomen. This is why some patients with undescended testicles, it can be intraperitoneal, and so they actually have to do a two-stage procedure to bring down the testes by giving them like testosterone injection, the children, the babies, the infants, to bring it down and into the scrotal sac. So when you have undescended testicle, it could be anywhere along this path that the testes take when they descend. The processus vaginalis descends into the inguinal canal. So the processus vaginalis is the continuation of the peritoneal lining, and so that goes external, or and into the scrotal sac. And this is the cause of patent processus vaginalis. Patients with hydroceles, typically this canal communication obliterates, but in some people it doesn't, and so you have a persistent opening, and so you have peritoneal fluid that goes into the scrotal sac, which is what a hydrocele is. And that kind of, it can be sort of, most of it is really localized to the scrotal sac, but sometimes you can have a hydrocele within the inguinal canal. Sometimes you can have a frank communication like this. So that's the processus vaginalis. The opening in the transversalis fascia produced by the invagination of the processus vaginalis becomes a deep ring. So this is the opening right here. So as it goes in, this parts of it, as I said, this obliterates. But then there's an opening here where the vas, as well as the spermatic cord, neurovascular structures, that is open, that where all of the structures go through the inguinal canal. When surgeons go in to repair an inguinal hernia, they can do a laparoscopic repair. So they'll go in laparoscopically and then put in a little plug here in the region of the inguinal canal to close off the hernia. So that's the deep ring that they're closing off. The testis arrives in the final position of the scrotum posterior to the processus vaginalis by 8 months. So the processus vaginalis is this part here. This is, we mentioned before, is a continuation of the peritoneum, and it can collect fluid that causes hydrocele. The testicle is posterior to that. So the pink one is the vas efferens, and then the green is the testes. The parenchyma, where the spermatogonia is produced, generated, and then it goes into the vas, the epididymis, and then up through the vas and into the ejaculatory ducts, into the urethra. Okay, so zooming into the testes, it's made up of a lot of seminiferous tubules, and they're like packed in, and then they all sort of centrally empty into the mediastinum, sort of like their kidney, and how all the collecting system, all the papilla drains into the renal pelvis, kind of similar. So that's the mediastinum, and then each lobule has 1 to 4 seminiferous tubules. So when we look at a cross-section of the seminiferous tubule, this is what it looks like. So seminiferous tubule is here, and then you have the parenchyma, the pinkish, dark pink material that has the supporting structures, the Sertoli cells. They serve as a scaffold, and then they promote the spermatogonia. So these little germ cells here, the spermatogonia, which then become mature spermatids and sperms. So the stroma contains the Sertoli cells. So the stroma of the testes contain the Leydig cells. I misspoke. The Sertoli cells are actually the scaffold cells between the spermatogonia. I'm sorry, I misspoke. These blue ones here are the Leydig cells, and they produce testosterone. And there is a communication between the Sertoli cells and the Leydig cells, which then support the development of the germ cells. So these little cells here are the Leydig cells. So I think most of you got it correct. The stroma, if not all, stroma of the testes contain the Leydig cells. The stroma, so that's the answer. So here is sort of a less zoomed in view of the seminiferous tubules. So this is where the sperm cells are created. And this is a cartoon of the layers of it. The Sertoli cells are the ones here. These are the scaffold cells that support the growth of the spermatogenic cells, which then differentiates into little spermatids. So the seminiferous tubules contain which, let me go, this, with my current view, I can't see all the answer choices, but the answers are on the next slides. So seminiferous tubules contain which cells? So it has the Sertoli cells, which are the support cells, the scaffold cells, and then it also has the spermatogenic cells. So the answer is A. I think most of you answered correctly. Sertoli cells, they secrete the antigen binding protein ABP, and that protein is what allows for binding of the testosterone, so that there's high level of testosterone within the region of the spermatogonia, because testosterone is needed. So it helps localize the testosterone to a high concentration through this protein, antigen binding protein. It produces the Mullerian inhibiting factor, which inhibits development of the female organs and structures. And then the tight junctions between the Sertoli cells, they form the blood-testes barrier. This is important because it prevents the gametes, the spermatids, from autoimmune attack. And it's temperature sensitive. So it needs to be in a lower temperature, a cooler temperature than the body temperature. So that's why it's external. And this is important because patients with cryptoorganism. The testes are either in the inguinal canal, or in some cases it could be intraperitoneal. Actually retroperitoneal. They heat up, and so patients with cryptoorganism have an increased risk of infertility because the testes are atrophic, because it's in a warmer climate environment than they're used to. But a cryptoorganism does not necessarily mean infertility. As long as they have one functional testes, their fertility rate is still like normal. So you only really need one testes to have normal fertility, but but the affected testicle will be atrophic and will not be able to have proper sperm production. Okay, so that's the importance of temperature. And so Sertoli cells are important for sperm cell synthesis, SSS. Okay, so question: bilateral cryptoorganism absolutely. Fertility would be a concern if the patient has bilateral cryptoorganism, because then you don't really have. It's like the kidneys, right? You can take one out and still have normal renal function. If you take both out, then then you need to be on hemodialysis. So actually, what happens is sometimes sometimes it's iatrogenic, right? Let's say they have cancer, then they know it's essentially going to be. They're equivalent of no longer having normal testicular function, let's say bilaterally, because of like a condition that they're treating, for example, not necessarily congenital like cryptoorganism. But in those cases, when fertility is desired or continued fertility is desired, then they'll harvest sperm and they'll put it into a sperm bank, so that if they get treatment for their cancer or whatnot and they lose their fertility, or they have to get surgery because of, say, I don't know, like cancer, like testicular cancer or lymphoma or whatnot, then they use the bank that's harvested sperm to then for future childbearing, for future family planning. The blood testes barrier. So the Sertolis have receptors for FSH, and let me see, there's like a bunch of little arrows and stuff. So this is the tight junction here. This is the blood capillaries, and then they go through the tight junctions, and then it goes. We said this is the support cells, the Sertoli cells. These are the little spermatogonia that then become spermatotids. So, anyways, there's like a continual communication, and then this is the extracellular space. So it has FSH. The energy, it makes the androgen binding proteins. This helps keeps the local testosterone levels high. Important for sperm production. And it also produces estradiol, which is important for, I guess, protein synthesis. In contrast, Leydig cells, these are endocrine cells, and they secrete testosterone in the presence of LH. So they produce testosterone. Sertoli cells capture the testosterone and keep a high local concentration through the androgen binding protein. Leydig cells are located in interstitium, and they're a homologue of the thecal internal cells. Right? So these cells are all, that means that you can have cancer from any of these cells. Germ cells are cancers of the spermatogonia, germ cell cancers. And then you can have also different kinds of Sertoli cancers, Leydig cell cancers. So any of these cells can transform, become malignant. But most commonly it's germ cells. Okay. So the question is, Sertoli cells have which receptors? So FSH is for androgen-binding protein and estradiol production, FSH. So that's the answer. I think most of you guys got that. And LH is Leydig cells, and these cells are in the interstitium, and they produce testosterone. We can go back and just. These are the Leydig cells outside in the interstitium. They make testosterone, which then crosses over the blood vessels and then into the Sertoli cells, because they have the androgen-binding protein to keep a high local concentration of testosterone needed for the production of or the differentiation of the spermatogonia into little spermatids. Vas deferens is the conduit that the spermatids travel through, and then eventually gets in through the ejaculatory ducts, and then when the men ejaculate, it comes out through the urethra. So these are the different segments of it. So you have the epididymis, which is this little curvilinear shaped structure here, and then it goes up the vas through the inguinal canal, exits the deep ring, and it comes out and over. It goes over the ureter, inserts over the ureter, and then goes to the seminal vesicles. Well, the seminal vesicles is where the juice is produced, but it goes up and into the ejaculatory canal, comes out the varimontanum, and through the ejaculatory duct. Okay, and the green one is the seminal vesicles. 7 up, the pathway of sperm production. This is from first aid. It goes through the seminal epididymis, we talked about already, vas, ejaculatory duct, urethra, and the penis. Venous drainage. The left testes, they have different drainages. The left testes, so the pampiniform plexus is like the venous complex that drains the testicles. So the left side comes directly from the renal vein. This cartoon is sort of misrepresenting because the right side, the right gonadal vein, is actually a little lower down here, not so close to the renal vein. But anyways, the left drains into the renal vein. In contrast, the right side drains directly into the vena cava. So there's different lymphatic drainages. And that's important because patients on the left, they have increased varicocele. The vein is more vertical, and so there's more sort of gravity pulling on it. So there's a higher risk of varicoceles on the left side. Varicoceles are dilated pampiniform plexus. And that's feels like a bag of worms, and that's problematic because it heats up the local temperature and can lead to infertility of the involved testicle. So that's why the left side is more prone to varicocele. And so they say if you have an isolated right side, then you need to image the patient because they can have compression of the vein, gonadal vein, from a mass, because we shouldn't see it on the right side. But as with many teachings in medicine, I mean, just like the question is, what's the prevalence and what's the predictive value? And my guess is they're low. So one other question, it could also be a clot, right? We don't typically see isolated clots in the gonadal vein. So the question is, if it's bilateral varicocele, does that also make you think of cancer? Most common cause of varicocele, just like cause of varicose veins in your legs, is from venous hypertension. So there's just high pressure veins, or there's valvular insufficiency, and so then you basically get varicose veins. That's the most common cause of varicocele. So let's just put it there. Now, going back though to the questions, which are very good, which is it could also be from a clot. So sure, if there was a clot, it could be, but if there was a clot, this is likely going to not be isolated. Meaning specifically, the clot is probably going to be covering the entire IVC cava. So I had one patient, for example, that had an IVC filter, and like the IVC was like totally clotted out. So then he had severe varicoceles, bilateral testes, because we did a testicular ultrasound, but he had collaterals everywhere because the IVC was out from the IVC, from the filter that was put in like 10 years ago, unfortunately, when he had some trauma. So yes, it could be from a clot, and in those cases, it's the clot is going to probably affect both sides because it's going to be central. The other question, if it's bilateral varicocele, does it make you think of cancer? Cancer, yes, that's a very good question because we know cancer is coagulopathic. Patients with cancer, for some reason, are just more prone to clots. They get PEs. There's increased risk of PEs. They get DVTs because that's what cancer does to people for some reason. So can you get a varicocele from a clot? Not isolated typically. We think more DVTs and PEs because we're thinking more central. But if it's like a really big clot, like an IVC, you take out the IVC, sure, you can potentially, take out the peripheral veins. But we don't really think of it in terms of that for patients with cancer. It's more of like the critically, like the DVTs that will then go on to becoming PEs. Okay, those are the two questions. Very good questions, though, because it sort of underlies the pathophysiology of this. But, most are due to venous insufficiency venous hypertension or valvular insufficiency, just like varicose. So the cause is most commonly benign. Let's go back. Okay, testicular tumors. So moving on to tumors. Germ cells are the most common, and then you have everything else, right? We said you can have these stromal tumors, Leydig cells, Sertoli cells, granulosa, like all the little other cells that are there can also become tumors or malignant. But the most common by far is deriving from the spermatogonia. And there's two subtypes, seminomas and non-seminomas. And they're like 50-50. Seminomas are the better one to have. They have better prognosis. They respond to treatments compared to non-seminomas, which are typically more aggressive. What is the most common test? Okay, so I think most, if not all, said germ cell, which is the correct answer. So it happens in young people. Risk factors, cryptorganism, Klinefelter syndrome. Patients, for example, with cryptorganism who have an atrophic testicle, that you can't recover the function, they typically will get an archaectomy to reduce the risk of testicular cancer. What else? Can present as a mixed germ cell tumor. They don't transilluminate. I don't know anyone, I've never seen like transillumination, but that's what's taught in the textbook, which are always like 10-15 years behind anyways. Or not me, sorry, that was kind of cynical. Textbooks are maybe 5 years behind. Some are 10 years behind. Types, you have seminomas, and then that's 50%, and then the other non-seminomatous tumors are the other 50. Seminomas look like this. They're solid tumors, and they're intratesticular. So when we think about malignancy, we categorize it into two broad categories. Is it intratesticular or extratesticular? If it's an intratesticular lesion, it's usually like malignant. If it's extratesticular, in general, we think it's like benign. So seminomas, non-seminomas, all of those masses, lesions, they're intratesticular. They are on path, it's homogeneous. It doesn't occur in infancy. It happens in young men. You can get this Friday appearance. It's radiosensitive, so patients can get radiation, and the tumors respond really well. And it has an excellent prognosis. The bicyclist Armstrong had like seminomatous testicular cancer with metastasis to the brain, and he did really well. This is a very good tumor. I mean, if you're gonna talk about the different testicular cancers, seminoma is a good one to have. It's just it's just not as aggressive, and it has very, very good prognosis. Seminomas metastasize to the retroperitoneal. You get lymphadenopathy, metastatic lymphadenopathy. This is what normal peritoneum should look like. So you have fat that surrounds the SMA, the aorta, IVC, right, and outlines all the structures. In patients with retroperitoneal lymphadenopathy here, you efface the fat plates, and you see how the aorta is being pushed upwards and being displaced by the soft tissue mass. So when you see this in a man, the next thing you have to do is check the ultrasound of the testicle or perform a scrotal ultrasound to look for seminoma. Okay, yolk sac is non-seminomatous tumor. We said, right, those make up 50% of the germ cell tumor. Yolk sac, as well as some of the other ones we're going to talk about, are more aggressive than seminomas. They produce AFP, so urologists, the biomarkers are used as part of the staging for testicular cancer. Porio. So question, does cryptoorganism cause decreased spermatogenesis or weird spermatogenesis, which leads to... So the question is, why does cryptoorganism lead to germ cell tumor? That's a very good question, and I don't know what the answer is. It could be both, you know. I don't know what the answer is, but you know, in general, whenever there's like increased inflammatory like changes, then you know, cells, if the cells are not in an environment where they're going to be happy and thriving, then they can always transform. As to why they transform in the setting of cryptoorganism, I don't know. We can probably look it up. But you have so much to remember that this is one of those things that's, well, no, that's a very good question. I don't know. Sorry. I don't know what the pathophys is that leads to transformation, but I'm sure there's a lot of smart people out there that that's studying the mechanism. And we could probably Google it offline. But very good question. Very good question. Embryonal carcinoma is another non-seminomatous testicular cancer, and they present as hemorrhagic mass. Remember, non-seminomatous tumors, yolk sac, embryonal mix, these have poor prognosis. Their seminomas are much better. That's a little typo. They usually present with other types, you know, like embryonal, yolk, they could be mixed. It can produce beta HCG, and this one can have normal ESP. Mature teratoma, so this is another non-seminomatous germ cell tumor. It's happens in adult men, can be cancerous, and it's benign in children. Testicular non-germ cell tumor. So we said germ cell was the most common, 95%. In germ cell, you have seminomas and non-seminomas. And then now we have the non-germ cell, right? This is the 5% of testicular cancer. So these are like all the other cells that are in the testicle. So Leydig is one of them, right? So this is what they look like. Golden brown color, contains these crystals. They produce androgens or estrogens. So then as a result, men can develop gynecomastia, and they can get precocious puberty. Question. Do male teratomas form hair and other structures that occur in women? No. Yes, that's a very good question, and the answer is no. And I don't know why. Very good question. How do I go back? Here, let's go back. This is what teratomas look like in men. In women, like you would get that that nastiness with sebum, all the three dermal layers. They look different. And the teratomas that you can have teratomas of the chest as well. Like those don't have hairs and teeth and other things either. So I think maybe just the dermoids, the ovarian have the hairs and sebum and teeth. Testicular Oh, we did this LADIG already. Testicular germ cell. Okay, this is another germ cell tumor, Sertoli cells, and they're also called angioblastomas. And then you can have sort of less common cancers like lymphomas, like primary testicular lymphomas, or sometimes like lymphomas that spread to the testes. Acute scrotum. Okay, now we're going to move on to acute scrotum. First, well, most commonly is from infection, epididymal orchitis, usually pyogenic bacterial, and it's spread from the epididymis. So it'll be urinary, and then you'll have retrograde infection, and then down into the scrotum, rather than like a direct extension from the skin, for example. So patients present with pain. So all the signs of infection, rubor, dolor, humor, like increased vascularity. It's incredibly painful, and there's increased vascular flow from hyperemia. So this is what an example ultrasound would look like. So here, the left testicle is inflamed, right? It's very red and is swollen and probably acutely tender. And when you do an ultrasound, you get hyperemia. So we get increased blood flow compared to the normal contralateral side. These are typically treated with antibiotics. Okay. Another acute scrotum that you have to think about is testicular torsion. This is a urologic emergency. There was a sentinel case at Cedars-Sinai sometimes back. A man came in with acute testicular pain. He was in the ER for like 6 or 7 hours. Like he didn't get triage right away. And then by the time they could take him to the OR, his testicle was ischemic. It was not salvageable. And then there was like a major lawsuit because they didn't triage him quickly because it's time sensitive. And so now whenever people come with acute scrotum, they get triaged pretty quickly to rule out testicular torsion. So this is time sensitive and it's a urologic emergency. Typically, it happens because the teaching is that there's like a bell clapper deformity. So normally you have the structures that hold it sort of north and south pole-ish in a patient with a bell clapper deformity. It's more central, so it's increased risk of rotation. So it'll rotate, once or twice or even several times, and depending on how many rotations, the risk of venous as well as arterial obstruction is higher. So typically the veins go out first because of the low pressure, and then the arteries go out later. So you can have torsion where only the vein is out, but you still get arterial flow. But the key is that you get pain, testicular edema, and so these secondary. So just because you have a little bit of arterial flow, it doesn't mean there's not torsion. It just means that it hasn't torn enough to take out the artery. Question. More central, meaning north and south poles, usually sit anterior posterior. Okay, so I just made up the north and south pole just so that I can be a little bit more explanatory, but it's more polar. So it's usually the attachment is sort of up here. In contrast, patients with bell clapper deformity, it's a little bit more rotated so that the axis of the testicle is not like up and down. It's not 90 degrees. It's more closer to 180 degrees. Not vertical. Yeah, exactly. And some people, it's just a congenital variation. And so that increases the risk of this rotation. Sort of similar to people with malrotation of the bowel, when the mesentery, when it's not like broad based, which happens with LADS band and other conditions, then there increased risk of volvulus and twisting on itself. Okay, testicular torsion. Of course, the complication is testicular infarct. So In this condition, the cremasteric reflex is absent. The cremasteric, and the reason is because the nerves are out. In contrast to epididymal orchitis, where the nerves are still fine. So the cremasteric reflex is where you rub the inner thigh, and that causes contraction of the cremasteric muscles and cause the scrotum to lift. That is absent with torsion because the nerves are also damaged. In infection, those are spared, so the cremasteric reflex is preserved. And on ultrasound, you get absent flow. And we want to try to salvage it within 6 hours for the best outcomes. So here's an example of a patient with torsion. So this is the normal right side. The left side, there's absent flow. In addition, what do you notice about the grayscale? Is it similar or is it different? Or it's hyperechoic. So this is hyperechoic, yeah. So this is hypoechoic. So the involved left testicle is darker. It's hypoechoic. It looks closer to fluid. And the reason is because a lot more edema. So the more edematous it becomes, the closer to fluid it becomes, and so it becomes more hypoechoic. And what else do you notice about the testicle? So we said no flow. It's darker. It's hypoechoic. And what's the third observation about this testicle that's not normal? And what about size? It's swollen. It's bigger, right? If you measured it, the testicle is larger than the right side. So these are all signs. You don't always have all of them, but these, the more positive signs you have, the more likely the patient will have torsion. So then if it is salvageable, then what they do is they tack it down. They do an orchidopexy, so it doesn't rotate anymore. In this case, it looks like it's infected, so they'll just do an orchiectomy and then put a prosthesis. Other causes of acute scrotum, this is a hydrocele we mentioned before that is typically because of patent processus vaginalis. And, that can happen in different places. So you can have a hydrocele of the cord where there's just obliteration of just the proximal aspect, but persistent hydrocele in the cord. It's varies as a spectrum, but it has to do with incomplete or non-obliteration of the processus vaginalis. And the urologist can perform a hydrocelectomy to resect it if it's symptomatic, large enough, or bothersome. Varicoceles are dilatation of the pampiniform plexus, and most commonly they're benign, just from venous hypertension or valvular insufficiency, but they can cause discomfort. They can cause pain. In some cases, it can cause infertility because the temperature in the scrotum is higher, and so then it leads to impaired spermatogenesis. There's two forms of treatment. One is to do a varicocelectomy with microsurgery. The urologist will go in and ligate off each vein and occlude it. The second is embolization. Interventional radiologists will access the common femoral vein and then superselect in this case, the left renal vein and then the left gonadal vein. And then they'll put embolization material to then cause occlusion of the vein. And they're both equally effective. Acute scrotum, other causes, so spermatocele. Spermatocele is when you have a diverticulum of the epididymis, as you see here, for example, at the head of the epididymis, and you have just sperm pooling there. And you can differentiate this from hydrocele on ultrasound. But it's uncomfortable sometimes. So then you can do a resection of the spermatocele. And this is what it looks like intraoperatively. Acute scrotum, other causes, this is gross, but this is fourniers, gangrene. This happens in patients who are like diabetic. Bad things always happen to patients with diabetes. And this is a urologic emergency because it's an aggressive infection and spreads rapidly, so they can become septic very fast. So it has to be aggressively debrided. This is not something that you treat with antibiotics. They go in and they just resect out all the infected material in the perineum. If anybody wants to watch how it's done, here's a video that you can watch on your own. I'm not going to play it because it's really gross. But this is how you treat fourniers. So question is, does spermatocele look more solid than anechoic? Spermatocele is fluid, but it's fluid with sperm. So it looks, it's anechoic. It's anechoic, except if it's super infected, but that's not very common. So how do you distinguish it on ultrasound? That's a very good question. So I wasn't going to go into the imaging details, but there's several ways. So spermatocele, it has sperm, so you can like press the transistor on it, and then it'll cause reflection of the sperm. That the acoustic wave will reflect off the sperm, so you could like see little dots. And you can see a wave sometimes as you push down, because the sperm will reflect some of the transducer sound waves. You mentioned it also, sort of the shape, right? Hydrocele, usually it's fluid around the testicle, and so it's more curvilinear and it encases it. In contrast, spermatocele is a little ball, and the ball is usually at the head, of the epididymis. Most spermatoceles are actually very small, and they're called epididymal cysts. So they don't, what I showed you is a very pronounced, a big spermatocele, but most are very small, and so we call them epididymal cyst. You don't do anything about it, but we'll do ultrasound sometimes because patient will feel a lump on their testes. Yeah, sometimes the big ones is hard to differentiate the two, but it's usually the shape, the morphology, and sometimes, like I said, you can do sort of maneuvers to try to solicit certain responses that you see with spermatocele, but you don't with hydrocele. So the question is, sperm is not possible to visualize in a normal testicle with pressure, right? Typically we don't, but sometimes what happens is you can cause a wave, you can cause a little bit of reflection. So collectively you can, we know, like, this is something that's sort of like published in review papers and peer review. We don't actually like to commonly do it during the ultrasound exam, because you can tell because of the location, because of the way it looks, like compared to hydrocele. But it's more of like an academic thing. You can like push on it, and then it'll cause the wave, and then the wave somehow causes the reflection, just a little bit, but it's very subtle, and you have to pay attention to it. And that you see typically, it's been reported with spermatocele and not with hydrocele, because hydrocele is just fluid. But it's academic, in clinical practice, people don't go there and like push the sperm or push the scrotum and look for the little waves. It's just really just more of an academic interest, because you can usually tell based on other morphologic features. Okay, fourniers, gangrene. So yeah, it's surgical debridement, and you have to be very aggressive until you get healthy tissue. Acute scrotum, hematocele is a clot. It's a blood clot, typically from trauma. You can have intratesticular hematomas or extratesticular. In this case, it's extratesticular. This is a testicle here. Here's the clot here, and it's causing mass effect on the testicle. So it's compressing the testicles. That's it. So these are the content that we reviewed, and that's the end of the lecture. Questions? Let me stop the recording.